So today we are starting the cardiovascular anatomy, embryology and physiology. So first of all, the cardiac embryology. So the heart is the first organ which develops and it beats by the week 4 of development. And the important thing is that as the heart develops, the first thing that happens is cardiac looping. Cardiac looping means that the heart establishes the right and the left polarity. It means that one side become the right side and the other side become the left side. What helps in developing this right and left polarity is the cilia. So there is if there is any problem in the cilia, for example seen in the primary ciliary dyskinesia in Carter-Jenner syndrome, the cilia is dysfunctional because the Dynein arms are not working. So what happens is that there occurs bronchiectasis. So the cilia does not beat and cannot clear out the mucus. It also causes male infertility because the sperm are not motile. Similarly, it also causes the dextrocardia. We know that normally the heart is towards a little left of the midline, but when the cilia does not work properly, the heart is towards the right side. Now the first chamber is the atria. How the atria develops is, the first step is the septum primum develops. Look at this diagram. This is the septum primum. It means the initial septum, and how it grows downwards towards the endocardial cushions. These are the endocardial cushions, and there is a space in between. This space is called the ostium primum. It means the first ostia that develops is the ostium primum, and as the ostium primum it meets the endocardial cushions, it leaves some cells, it degenerates some cells here, that becomes the ostium secundum. So just remember that the ostium secundum is the second formed ostia, but it is formed where? In the septum primum. So the first ostia in the ostium primum is the septum primum is the ostium primum, and the second septum that develops in the septum primum is the ostium secundum. And then further what happens is that this septum primum, it eventually meets the endocardial cushion, as in here you can see, and the septum ostium secundum is still there, that the next septum called septum secundum starts developing to the right of the septum primum. This septum secundum, it covers this space in the ostium secundum. So this space becomes a very small, known as foramen ovale. And we know that in the fetal circulation, we'll study that the right-sided pressures are more than the left-sided pressures. So blood flows through this patent foramen ovale from the right atrium towards the left atrium, and from here it goes into the aorta. But after birth, what happens is that the pulmonary vascular resistance falls and the right-sided pressures becomes less than the left-sided pressures. So this septum just presses against this septum secundum, and it results in a functional closure of the foramen ovale. So and after a few days it becomes anatomically closed as well. If this foramen ovale remains patent after birth, it will result in a paradoxical emboli, which means that the emboli moves from the right side of the body, and then it moves toward this patent foramen ovale and stuck somewhere in the systemic circulation. For example, in atrial septal defect, in which the septum is not formed completely. So now how the ventricles develop. So just remember that the ventricle develops from two sources, as we know that the septum of the ventricle, interventricular septum, it has two parts. One is the muscular part and the other is the membranous part. So the muscular part, it develops here, and then there is a septum called aorticopulmonary septum. It spirals It spirals, so it gives rise to pulmonary trunk on one side and the aorta on it. And this spiraling is very important, and for this spiraling we need the neural crest cells. And if the neural crest cells does not migrate properly, this septum is not formed. So when this septum is not formed properly, it results in conotruncal diseases. Conotruncal abnormalities means that the outflow tracts are not formed. It is one of the part of the Digeot syndrome as well, so which results in the second and third pharyngeal arches are not formed properly, and it results in decreased immunity, conotruncal abnormalities, so thymus is not developed. So when the neural crest cells do not migrate properly, the ascending aorta and the pulmonary trunk are also not formed, and it results in transmission of the great vessels, tetralogy of Fallot, and persistent ductus arteriosus. Now, if the septum is not formed completely, it will result in a hollow systolic murmur, harsh hollow systolic murmur of the VSD. So we will study that in detail in congenital heart diseases, which is basically acyanotic heart disease. And the valves, so there are two types of valves, the mitral and the tricuspid, and the aortic and the pulmonary. The aortic pulmonary valves develop from the endocardial cushions. These structures are really important. In the Down syndrome you will study these. And the mitral and tricuspid valves are derived from fused endocardial cushions of the AV canals, while the aortic and pulmonary are formed from the endocardial cushions of the outflow tracts. So about the arches, I will make a separate video on this, but just remember that the first arch, the artery of the first arch is the maxillary artery, the second has stapedial, and the third is common carotid. You can remember it by the letter 3, common carotid. And the fourth has on the left the aortic arch, and on the right the subclavian. And the fifth is not, because that regresses. The sixth, it forms the pulmonary arteries on the left and ductus arteriosus on the right. Now, what are the primitive derivatives? So if you look at this diagram here, this one is the truncus arteriosus. The truncus arteriosus, it gives rise to that the truncus arteriosus. So basically, as we studied earlier, then the neural crest cells are important for its formation, and the truncus arteriosus basically form two structures. The one is the ascending aorta on the left side and pulmonary trunk on the right side. Beneath that is the bulbous cordus. The bulbous cordus form the smooth part of the left and the right ventricle. So the left and the right ventricle has two parts. One is the trabeculated part and the other is the smooth part. The smooth part arises from the bulbous cordus, while from the primitive ventricle only the trabeculated part arises. Similarly, the primitive atrium gives rise to the trabeculated part, while the coronary sinus is a structure which is directly connected to the right atrium of the heart. So if the pressure rises in the right atrium, it will enlarge the coronary sinus as well. It is formed from the left horn of the sinus venosus. This is the sinus venosus. There are two horns, the left and the right. So from the left side the coronary arises, and from the right horn of the sinus venosus, the smooth part of the right atrium, which is also known as the sinus venerum, arises. The endocardial cushion rises to valves mostly, and the septa in between. And the right common cardinal veins and the right anterior cardinal veins form the superior vena cava, while the posterior ones form the inferior vena cava. So these are the primitive derivatives. Now the important thing is fetal circulation. So in the womb, the baby gets its nutrition and oxygen from the mother. So there is no need for the lungs, because the lungs are not functional in the womb. But after birth they gets functional, so the circulation changes to adult circulation. But here we will discuss about the fetal circulation. The fetal circulation, there are two umbilical arteries and one umbilical vein. The umbilical vein carries oxygenated blood, even though it is vein, and the umbilical arteries carries the deoxygenated blood. And there is one umbilical vein and two umbilical arteries. They are connected to this placenta. So from placenta, what happens that oxygenated blood passes into the umbilical vein and it reaches the liver. On reaching the liver, it bypasses the liver through a structure called ductus venosus. So the first shunt in the fetal circulation is the ductus venosus, through which the oxygenated blood bypasses the liver and reaches where? Inferior vena cava. From here, the blood reaches the right atrium. From right atrium, the blood reaches the left atrium. As we studied that the right atrial pressures are larger than the left atrial pressure, so when it reaches the left atrium, through which foramen? The second shunt called the foramen ovale. And from here, when it reaches the left ventricle, it leaves the heart through aorta and reaches the systemic circulation. And from here, the deoxygenated blood from the lower parts of the body and the rest of the body is collected through the umbilical arteries, and then it reaches the placenta again for oxygenation. And the blood from the superior vena cava is also deoxygenated, so it reaches the right atrium. And if some little bit of blood even trickles down and reaches the right ventricle, and it tries to escape through this pulmonary trunk, it still cannot reach the lung. Why? Because there is a third shunt called the ductus arteriosus. To the ductus arteriosus, the blood is bypassed from the right ventricle and pulmonary trunk to the aorta, and it reaches again to the body. So there is no need of the lungs. The blood just circulates this way, that first of all, the blood reaches the umbilical vein. It bypasses the liver and reaches the ductus venosus to the inferior vena cava. From here, it reaches the right atrium and leaves through foramen ovale, the second shunt, into the left atrium, and then to the left ventricle, and then to the aorta. And if some blood from the superior vena cava reaches the right atrium and then the right ventricle, and then leaves through pulmonary trunk, even that leaves through ductus arteriosus into the aorta. So that way the blood keeps on circulating. You notice that here the partial pressure of oxygen is very little and the saturation is also very little, but we know that the fetal hemoglobin has highest affinity for oxygen. So even this less saturation and partial pressure is enough to keep the fetal blood in circulated form. So sometimes what happens is so what changes happens after birth? At birth, what happens is that the infant takes its first breath. With that cry, the pulmonary vascular resistance falls. So when the vascular resistance falls, blood rushes into the lungs. When the blood rushes into the lungs, where will that blood be poured? Into the left atrium, of course. That will result into the higher pressures on the left side. And the second reason that the left sided pressure rises is that the low pressure circulation, which was placenta, is also lost. So when the low pressure circulation is just lost, so the systemic BV is established and the systemic blood pressure rises, so the left sided pressure also rises. That way the left sided pressure rises, so it leaves the left atrium into the left ventricle and then to systemic circulation, and the foramen ovale is first functionally and then anatomically closed. And also when you take your first breath, the oxygen saturation just increases and the prostaglandin falls, because the prostaglandins that were released from the placenta, now the placenta is not there, so that falls and oxygen rises. These two factors are important for closure of the ductus arteriosus. So when the ductus arteriosus closes, the connection between the pulmonary trunk and the aorta is also lost. So there is the right and the left side polarity established of the blood circulation. The blood no longer mixes on the right and the left sides. If there are some congenital anomalies in which there is no communication between the right side and the lungs, so we have to keep the baby alive. For that, we need the blood to pass to the lungs. And the only shunt that is kept open is ductus arteriosus, and that is very important. So to keep it open, we need prostaglandins, because initially prostaglandins from the placenta was keeping it open. Now that is lost, so we therapeutically keep it open through prostaglandin E1. Sometimes it is not closed and we want it to be closed, so we give the patient NSAIDs. Why? Because NSAIDs inhibit prostaglandins, and the removal of the prostaglandins, it is important for closure of the ductus arteriosus. So that was all about the fetal circulation. Now just summarize a little bit that in utero and at birth, pulmonary vascular resistance, what happens to right atrial pressure and what happens to left atrial pressure. So we know that pulmonary vascular resistance is pretty high in utero. The right sided pressures are high and the left sided pressures are low. After birth, the pulmonary vascular resistance falls. That results in blood rushing into the lungs, and that results in increase in left sided pressure and fall in the right sided pressures. What are the derivatives of these shunts? So the ductus arteriosus, which we studied here, was the first shunt, and it is changed into ligamentum arteriosum, and it's here ligamentum venosum. It is changed into ligamentum venosum, while the PDA is changed into ligamentum arteriosum. And you know that the left recurrent laryngeal nerve, it just moves around this ligamentum arteriosum and then goes upward into the thorax. The foramen ovale form the fossa ovalis. The allantois, these are just not related to allantois is not related to fetal circulation, but median umbilical ligament is formed from here, and umbilical artery form the medial umbilical ligament, and the umbilical vein form the round ligament. Now a little bit about anatomy. This is not too much detailed anatomy, but just important points. Just look at this diagram. This is an cardiographic diagram. You have studied in cardiac murmurs that we do that transesophageal echocardiogram and transthoracic echocardiogram. So look at this chamber. This is the most posterior chamber of the heart. This is the left atrium. So the left atrium is the most posterior chamber, and this is aorta. And in between this structure, it is not shown here, but here lies the esophagus. So whenever the left atrium enlarges, and why it enlarges? Due to mitral stenosis, it will compress on the esophagus. It will compress on the esophagus, it will cause dysphagia, and it also compress on the left recurrent laryngeal nerve, which rounds around the ductus arteriosus, which becomes the ligamentum arteriosum, the remnant. So when it compresses against these two structures, it causes dysphagia and hoarseness. This is known as Ortner syndrome. We'll study this again in the mitral stenosis. When mitral stenosis happens, the left atrium enlarges and it compresses against the posterior structures, which are the esophagus and left recurrent laryngeal nerve, resulting in dysphagia and hoarseness. Now look at this is the sternum. These are the ribs. So this is the most anterior structure, the right ventricle. So in any trauma, it is the most commonly injured chamber. And look at here, the right ventricle. The right ventricle is the inferior, the diaphragmatic surface of the heart. Now about the layers of the pericardium, there are three layers. Endocardium is the most inner layer of the heart. Myocardium is the most thick layer, while the pericardium is the outer layer. And the pericardium is again divided into epicardium, fibrous pericardium, the parietal pericardium, and the epicardium. There is a space in between the parietal and the visceral pericardium, which is known as pericardial space. You will study that in pericardial tamponade and pericarditis. So these are the layers. And you should remember that the epicardium, which is the visceral pericardium, which is the layer most near to the heart, like from inside to outside, the most inner layer is endocardium, then is the myocardium, then is the epicardium, and the outer layer are the fibrous pericardium and the pericardium. This layer, the epicardium, contains the coronary vessels. Now, the most important topic in this is the blood supply. So regarding the blood supply, you will be asked questions in the U word, like if a person was working in snow and suddenly developed a chest pain on the left side, which was radiating towards the jaw and the shoulder, and on echocardiogram the anterior wall of the heart is hypokinetic, which blood vessel is occluded. So just remember the areas which are supplied by the certain vessels and you will answer those questions easily. So remember these few vessels like left anterior descending artery, left circumflex artery, posterior descending artery, and the right coronary artery. So the left anterior descending artery supplies the anterior two-thirds of the interventricular septum, the anterolateral papillary muscles. There are three papillary muscles, two anterolateral and posterior medial and papillary muscle, posterior medial and anterolateral. Just remember these. And most of the anterior surface of the left ventricle is also supplied by the left anterior descending. The marginal artery supplies there is a marginal artery, so it supplies the right ventricle. The right coronary artery, it supplies the AV node, the SA node. This is important. Just remember this, that the SA node and the AV node are supplied by the which artery? Right coronary artery. An infarct may cause bradycardia or heart blocks. And the posterior descending artery supplies by the posterior interventricular one-third of the interventricular septum and the posterior third walls of the ventricles. So anterior one-third, two-third of the interventricular are supplied by the LAD, and the PDA supplies the posterior one-third of the interventricular septum. Now there are two muscles, anterolateral papillary muscles and posterior medial and papillary muscles. So what happens is that the anterolateral papillary muscle, it has dual supply. It is supplied by the left anterior descending as well as the left circumflex, while the posterior medial is supplied by the right coronary. So this is more vulnerable to ischemia than the anterolateral. And we have studied that in the complications of myocardial infarction, that the rupture of the posterior medial muscle cause severe mitral regurg and heart failure. Now about the right dominance. So in 90% of the patients, the right coronary artery gives rise to posterior descending artery, while the 10% of the patients there is left dominance, that the PDA arises from the left circumflex artery, while in the rest of the patient there is codominance, that the PDA arises from both. Now what is the the rate of occlusion? So occlusion mostly occurs in left anterior descending, and then in the in the right coronary artery, and then in the left circumflex. So this is the rate of, mostly this one is occluded. This was all about anatomy. In the next video we will discuss about the congenital heart diseases.